The patient is a 55-year-old woman with a medical history of morbid obesity, 130 kilos and diabetes mellitus treated with metformin. In addition, she complained of urinary incontinence, and she had a previous admission 4 months ago due to a complicated urinary tract infection caused by an ESBL E. coli. For that reason, she received 7 days of ertapenem. She was admitted to the emergency department due to 5 days of fever chills and muscle pain. She was treated initially with paracetamol, but she presented progressive dyspnea. During her physical examination at the emergency department, she was febrile. Her blood pressure was 90/64, and her heart rate was 140 beats per minute, the breath rate 35 per minute. C-reactive protein was 45 milligrams per deciliter. The leukocyte count, 14,780 cells per cubic millimeter, and 92% of neutrophils. The hemoglobin, platelets, creatinine, and glomerular filtration were normal. Lactate was 28 milligrams per litre, and a chest X-ray showed a consolidation of the superior part of the right lung that's compatible with pneumonia. The patient was admitted under influenza treatment and was treated initially with oseltamivir, ceftriaxone IV, and azithromycin IV. The patient's condition progressed to respiratory failure with the need of mechanical ventilation and vasoactive drugs, which resulted in admission to the ICU. Urinary antigens of pneumococci and Legionella and blood cultures were negative. And importantly, a nasopharyngeal swab was positive for influenza A following a PCR test. Respiratory sample in the sputum showed mixed flora. During her admission in the ICU, the inflammatory response increased after a 3-day decrease, and she was not doing well. Additionally, a CT scan showed the global effusion consolidation and necrotizing areas in the right upper lobe, as well as in the left lower lobe. The bacterial culture of low respiratory tract sample was negative. A BIOFIRE Pneumonia Plus panel was ordered and was positive for Staphylococcus aureus as methicillin sensitive. Ceftriaxone was replaced by ceftaroline 600 mg every 12 hours. This is a 4th-generation cephalosporin, much more active against Staphylococcus aureus compared to ceftriaxone. In summary, this was a severe case of community-acquired pneumonia caused by influenza with a bacterial co-infection. Bacterial co-infections are frequent in severe influenza pneumonias. The patient's condition significantly improved and she made a full recovery. The use of a BIOFIRE Pneumonia Plus panel on this patient treated with ceftriaxone helped to detect Staphylococcus aureus, which wasn't revealed by bacterial cultures, potentially due to prior antibiotic treatment. The BIOFIRE Pneumonia Plus panel delivers fast, accurate pathogen identification in about 1 hour, which may allow physicians to initiate appropriate therapy more promptly for patients, reducing unnecessary antibiotic use and improving overall care.